Thank you for allowing me to present and discuss today the topic of endoscopic ultrasound-guided radiofrequency ablation in the pancreas. So among the established techniques for eradicating solid tumor, such as esophageal adenocarcinoma and hepatocellular carcinoma, includes radiofrequency ablation, RFA. And RFA involves delivering a high-frequency alternating current that increases the temperature inside cells, which induce coagulative necrosis of the targeted tissue, leading to apoptosis. RFA causes tissue injury by focal hyperthermia, which is thought to alter tumor microenvironment, ultimately damaging cells at the membrane and at the subcellular level. Temperatures between 60 to 100 degrees Celsius are generated by high-frequency alternating current, and the ions in the tissue attempt to follow the changing direction of the alternating current. Post RFA ablation, the lesion is noted to have three zones: central one of coagulative necrosis, peripheral one or transitional zone of a sublethal hypothermia, and a surrounding unaffected tissue. Temperature greater than 100 degrees Celsius is less effective, as the ablation at this temperature causes water to become vapor and burn the tissue, resulting in an increased tissue impedance, but in a decrease of efficacy. RFA is also believed to have immunomodulatory effects. It is postulated that the systemic immune response from the release of tumor-related antigens in RFA could contribute to a durable oncologic response. Because in addition to direct injury, RFA is postulated to also induce an immune response. And in the transitional zone we saw earlier, multiple studies have shown an increase in inflammatory infiltrate, as well as B cells, T cells, and that are specific to the ablated tissue. These immune cells were noted in distant untreated tumor and also in the bloodstream. So various immunogenic intracellular substrates released post-hypothermic injury, like RNA, DNA, heat shock protein, and high mobility group protein, trigger an innate immunity to the tumor tissue. In fact, some small studies have also shown an improvement in the survival among patients with unresectable pancreatic adenocarcinoma with use of palliative RFA. In terms of its endoscopic application, RFA has already an established role in the treatment of Barrett's esophagus with dysplasia and the prevention of esophageal adenocarcinoma, which we use regularly. Another technique we also use in endoscopic RFA is RFA during colonoscopy for stricture in intrahepatic or in bile duct in a palliative setting. However, its use with EUS in the context of a pancreatic lesion is a newer but demonstrably safe concept. RFA of a pancreatic lesion using EUS guidance offer a real-time imaging guidance and visualization that lends itself to precision and minimally invasiveness. Currently, the only FDA-approved device for airways RFA is the one done by Taewong Medical USA. It is a single-use 19-gauge RFA needle with an active tip length ranging from 5 to 15 millimeter, and the EOS RFA probe can deliver a current that generates high temperature and electromagnetically, which can induce cell apoptosis and cognitive necrosis. This frequency is maintained continuously at a set of wattage until complete ablation is achieved at the impedance value of 800 ohm. Once this impedance level is reached, the power output automatically cuts off, thus preventing further tissue damage. This system also includes a water pump, which cools the electrode tip by circulating saline at a lower temperature to reduce tissue char. And here I would like to show you a very short video of how it is performed. Give me 1 second. Oops, I'm sorry. So the video seems to work, but I don't want to show you the whole video, just a few seconds of it. There you go. Oops. Music is maybe not ideal. Here we go. So exactly. So you start by performing regular, as you would perform regular endosonography to do FNP, for example. And you have a direct endosonographic visualization of the lesion. And then you would use the RFA needle as you would use a 19-gauge FNP needle to puncture and enter the lesion with the metal catheter. And then you can see in the EOS imaging as well as in the model that you need to burn in the so-called fanning technique, where you pinpoint small areas of the lesion until you can burn it completely. And there you see on the EOS imaging the bubbles that were applied. So here you see a little bit of air and the bubbles that are applied by the tissue apoptosis and charring. So let me get back to the presentation. Here we go. There you go. So currently, surgical resection represents the only potential curative means of treating pancreatic cancer. Conceivably, EOS RFA has multiple potential roles in the management of pancreatic adenocarcinoma, including downsizing tumors to improve surgical candidacy, ablating unresectable tumor as a part of a multimodal treatment approach, or as a palliative measure. Excuse me. Here you see on this computer tomography images a scan of a lesion in the pancreas. It's pancreatic head cancer before and after radiofrequency ablation. The small white dot you see is a plastic stent visible in the bile duct. Here you have another example, also pancreatic head cancer, which you see here on this image. The image B is the EOS with application of the RFA, and then you can see 1 month after RFA in build C, with necrosis and air bubbles in the mass, and 2 months after, showing a decrease of the low density mass. And the last example, last imaging example, this is an example of a neuroendocrine tumor in the head of the pancreas before ablation. Here you see the hyper intense tumor characteristic of a neuroendocrine tumor, and in the B image, it is 5 days after a second round of RFA ablation, where you see a non-enhancing area of low attenuation surrounding by ring-like enhancement. Of course, thermal ablation can lead to inflammation with fibrotic and cystic transformation. And among the potential adverse events of pancreatic RFA includes pancreatitis, gastric wall injury, bowel injury, pancreatic duct injury and stricture, and bile duct injury, leakage, as well as, in the worst cases, peritonitis. The safety profile of EUS RFA has been explored in several animal and human studies, which have yielded promising results. And the most common reported complication were abdominal pain and acute pancreatitis. One of the largest and earliest prospective study of ultrasound-guided during laparotomy RFA of a locally advanced pancreatic adenocarcinoma was surgical safety and feasibility study, including 50 patients, and their ultrasound-guided RFA during a laparoscopic surgery was found to have a favorable safety profile, which has further improved by reduction of RFA temperature from 105 degrees Celsius to 90 degrees Celsius. And this was correspondingly a reduce of the complication rate from 25% to 4% respectively. So partly due to the reduction in RFA temperature, early clinical study of EUS RFA found far fewer pancreatic complication with endoscopic RFA than with surgical RFA. This table summarize the latest published studies involving EUS RFA for pancreatic cancer. Long-term outcomes of EUS RFA in the setting of unresectable pancreatic cancer were evaluated in more recent studies. O and colleagues published an observational prospective studies on 22 patients. That was in 2022. So 22 patients, 14 with locally advanced disease and 8 with metastatic disease who received EUS RFA and subsequent gemcitabine-based chemotherapy. So the median number of EUS RFA treatment was 5 for this patient. And as treatment had been repeated for radiologic tumor burden reduction. And a complication rate of 3.74% was reported out of the total of 107 procedures performed. And notably, they found a median overall survival of 24 months among patients treated with EUS RFA. In another prospective study on also in 2022, 10 patients, so 7 with locally advanced disease and 3 with metastatic disease, Dosani and colleagues reported a median overall survival of 20.5 months following the successful treatment of the patient with EUS RFA and conjunction with systemic chemotherapy. So these patients received 1 to 4 EUS RFA-based treatment, and it was based on completeness of ablation. Tumor progression was observed in 2 patients, while tumor regression was recorded in 7 patients. 2 patients remained alive at 61 and 81 month follow-up after initial diagnosis, and the latter of which originally had metastatic pancreas adenocarcinoma, but became a surgical candidate and underwent laparoscopic pancreatic following extended chemotherapy and 2 RFA treatments. Here an example of one case in an older case series where 2 months after RFA for a non-resectable mass of the pancreatic head, a histological specimen of the tumor was obtained from a patient who required gastrojejunostomy for duodenal stenosis. I find it interesting because it shows histologically the fibrosis and necrosis in the sample tissue here. Here you see on the right-hand side all the fibrosis, and in this case, a single small, so less than 5 millimeter area of neoplastic cells was still to be found. Immunological studies are being undertaken for the RFA of pancreatic lesions, and some of which have suggested an adaptive immune response due to the effect of RFA. Giardino and colleagues reported a significant decrease in cytotoxic T cells and dendritic cells between day 3 and 30 among 10 patients following RFA for locally advanced pancreatic cancer. In addition, interleukin-6, so IL-6, a pro-inflammatory cytokine, was markedly elevated among those patients on day 3, and by day 13, dendritic cells level continued to be elevated while IL-6 level returned to baseline. Taken together, RFA appears to elicit more than a simple inflammatory response, but may have sustained effect on the adaptive immune system that could confer a durable response upon treatment with US RFA. While most of those studies center around malignant tumor, it is conceivable that these immune effects could be extrapolated for pancreatic neuroendocrine tumors and precancerous pancreatic cysts. And speaking of cysts, based on multiple criteria, as you know, pancreatic cyst lesion with high-risk stigmata of malignancy and so-called worrisome features are considered for treatment. The current standard of treatment of those precancerous cysts is a surgical resection. But emerging modalities in the non-surgical management of pancreatic cysts include endoscopic techniques, and the most studied of which are US-guided alcohol ablation and US chemoablation. US-guided alcohol ablation is associated with a higher rate of pancreatitis, presumably from alcohol extravasation in the surrounding pancreatic parenchyma, compared to chemoablation with paclitaxel. So US RFA is a newer option that takes advantages of the surgical efficacy of RFA in solid tumors. And of note, so here you see in this image, quite big, so 4 centimeters, 40 millimeters by side branch IPMN before and after ablation with RFA. We also need to note that in order to perform RFA on cysts, you also need to aspirate as much fluid as you can. Of note, while all endoscopic strategies show potential, they have not yet been proven to reduce the risk of high-grade dysplasia of pancreatic cancer, and hence multi-center clinical trials are needed to validate the clinical benefit of these methods. Long-term outcomes of US RFA for precancerous cysts have not been established. However, a prospective multi-center trial by Bauchzentrum and colleagues that originally focused on safety, so involving 40 patients with a neuroendocrine tumor and 17 with cysts, provide some insight. In the long term, so 3-year follow-up study, among 15 of the 17 patients with pancreatic cysts, 2 of them died to unrelated cause. Bachte and colleagues found that 6 had continued complete resolution, and 4 had an increase in diameter of more than 50%, representing an overall significant response of 67%. 3 patients had a recurrence of small cysts ranging from 4 to 7 millimeter. And this study suggests that overall long-term outcomes of EUS RFA for precancerous cysts are promising. The author also theorized that the systemic immune response, as we already discussed due to the RFA, could be partially responsible for the long-term response. And similarly to precancerous cysts, pancreatic neuroendocrine tumors, so either functional or more than 1 to 2 centimeters in size, are often treated by more than 2 centimeters in size, are often treated by surgical resection via a pancreaticoduodenectomy or distal pancreatectomy. Some guidelines recommend that patients with PANNET who are unfit for surgery should receive annual imaging for lesion with a size less than 10 millimeters and biannual imaging for lesion from 10 to 20 millimeters. So this consideration places the potential of the endoscopic treatment for tumor ablation in PANNET in a unique light. In fact, a recent, this year, retrospective study, comparing the safety and long-term outcomes of EUS ethanol ablation and surgery among 188 patients showed a comparable 10-year overall and disease-specific survival rate, while the EUS branch had fewer complications and shorter hospital stay. EUS RFA has also been described in multiple studies for the ablation of PANNET. Recently, larger multicenter study on the EUS RFA of PANNET substantiated that these earlier study regarding efficacy, feasibility, and safety. Bachte and colleagues reported a prospective study of 28 patients undergoing EUS RFA for either PANNET or pancreatic cyst. And in the neuroendocrine arm, 12 patients had a total of 14 non-functional PANNET with a mean size of 13.4 millimeter. And the EUS RFA of these 14 neuroendocrine tumors resulted in 12 with a complete response at 12 months follow-up, representing a significant response and more than so 50% decrease in size with a rate of 85.7%. So this significant response rate of 85.7% was consistent at 3 years follow-up. In 2019, Olekonov and colleagues reported on 18 patients from 2 tertiary centers, 7 of which had insulinomas, while the remainder had non-functional PANNET. And they were 27 lesions in total with a mean size of 14.3 millimeters, and complete response was observed in 26 of the 27 lesions. That's a 96% rate. No complication were observed during the procedure, and additionally, no recurrence was reported at a mean follow-up of 8.7 months. So RFA has been successfully used in dysplasia and solid tumor, multiple facets of the gastroenterology and oncology, including esophageal adenocarcinoma and hepatocellular carcinoma. Endoscopic ultrasounds enable the application of RFA in pancreas which offer precision and minimal invasiveness. In addition, it is believed that RFA elicits a systemic immunological response, which could contribute to a durable response. The efficacy of EUS RFA for various pancreatic lesions still needs to be elucidated, given the small sample size and lack of long-term follow-up in the current reported study. In summary, EUS RFA is an emerging modality for various pancreatic lesions, and EUS RFA will likely have a defined role in the treatment of precancerous pancreatic cysts, pancreatic neuroendocrine tumors, and pancreatic adenocarcinomas in the next decade. And with that, I conclude my presentation, and I thank you for your attention.
Thank you, Riad, very much for this very well-rounded description of this emerging technique. Are there any questions from the floor? I mean, just to start, I just want to let you all know we have this equipment available in our department, and I mean, I just want to raise awareness that it's a feasible technique, and for very highly selected patients, it could be applied, and of course, always after interdisciplinary discussion to find the ideal candidate that can profit from this emerging technique.
Darf ich was fragen?
Ja.
Habt ihr auch so, wir machen ja in der Leber manchmal Hydrodissektion, wenn direkt in der Nähe irgendwelche gefährlichen Strukturen sind. Ist das für euch auch eine Möglichkeit, das Pankreas jetzt noch mehr umgeben von kritischen Strukturen, dass man sozusagen perkutan ultraschallgesteuert noch Wasser oder man kann ja verschiedene Sachen da applizieren?
Das ist in dem Fall nicht beschrieben, dass wir Wasser injizieren, um den Abstand noch zu vergrößern. Wir brauchen mindestens 3 bis 5 Millimeter Abstand von den großen Gefäßen, oder? Das ist die Voraussetzung, aber es ist, soweit ich in der Literatur das gesehen habe, ist es nicht beschrieben, dass wir in dem Pankreas etwas injizieren, um Gefäßstrukturen zu schützen. Wahrscheinlich in der Leber die Situation anders, weil...
ja, nicht in die Leber, sondern einfach zwischen zum Beispiel Leber und Gallenblase kann man die so ein bisschen abheben. Oder wenn der Magen ganz nah dran ist oder das Kolon. Also einfach nicht ins Organ selber, sondern direkt, um die Organe voneinander zu trennen oder die Organstrukturen oder die anliegenden Gefäße durch die Kälte einfach dann ein bisschen von der Hitze zu schützen.
Das wäre mir nicht bekannt für Pankreashelfer.
Und die Mikrowelle ist noch nicht available, oder? Für die Endoskopie? Also, dass man sie durchbekommt, technisch, rein technisch?
Ich glaube nicht.
Soweit ich weiß, habe ich gar nicht davon gelesen. Nein.
Ich habe auch noch ganz kurz eine Frage. Danke für die schöne Zusammenfassung. Wie seht ihr die Möglichkeiten bei Patienten, die sind ja nicht so häufig, aber mit diesen biliären intraepithelialen Neoplasien, wo wir nie ganz sicher sind, ob wir da noch vielleicht irgendwie ein ganz kleines In-situ-Karzinom verpassen. Gibt es da Möglichkeiten mit RFA oder riskiert man dann Nekrosen von den Gallenwegen, den extrahepatischen Gallenwegen?
Absolut, Vanessa, es gibt durchaus Daten, sowohl für die intraepithelialen Neoplasien vom Gallengang, aber auch für die Papillenadenome mit Beteiligung vom DHC, dass man, wenn man das Papillenadenom abgetragen hat und noch kleine Reste im DHC drin sind, dann kann man noch RFA intraduktal machen, um diesen Resttumor noch zu abladieren. Und auch für andere Patienten, die nicht fit für Chirurgie sind, das ist durchaus eine valide Option.
Ja, Riad, vielen Dank für die schöne Präsentation und diesen Überblick. Sicher gut, dass wir das auch anbieten können in unserem Zentrum. Von meiner Seite, am interessantesten sind natürlich die Härte Immuncinatus. Da haben wir eine gewisse Distanz zu den Gefäßen und chirurgisch sind die schwierig, weil das Pankreas fast nie gestaut ist. Jetzt zu den Zysten vielleicht noch eine Frage. Du hast gesagt, man muss möglichst viel aspirieren. Jetzt, was mir in der Literatur häufig fehlt, ist eine exakte Diagnostik, bevor man die Ablation macht. Wir haben ja die Schwierigkeit, die Zysten wirklich genau zu charakterisieren. Kannst du da noch etwas dazu sagen? Soll man zuerst mal das mal leerpunktieren, alles analysieren und dann in einem zweiten Schritt vorgehen? Oder was denkst du, wo stehen wir heute?
Also es gibt natürlich bis jetzt keine offizielle oder Algorithmus in die Richtlinien, aber ganz genau, ich glaube, das ist sehr wichtig, dass vor man solche Interventionen macht, als wie beim Chirurgie. Man sollte vorher die Zysten punktieren, möglichst eine NGS-Panel, also Next-Gene-Sequencing-Analyse auch machen und den Zyst so weit wie möglich entleeren. Das wird auch helfen, wenn wir dann entscheiden, dass es könnte ein Kandidat für RFA sein, diese Intervention durchzuführen. Warum sollte man den Zyst vor die RFA entleeren? Es geht genau, wie wir haben dann diskutiert mit Anja, es geht um die Umgebungsstrukturen zu schützen, weil wenn man Hitze in Flüssigkeit dann applizieren, es könnte sein, dass, also soweit ich gelesen habe und die kleinen Serien, die Autoren beschreiben war, dass die Hitze in den Flüssigkeit appliziert, macht eine größere oder wenig kontrollierte Hitzeschaden in die Umgebungsstrukturen. Was man auch sehr aufpassen muss, vor allem in Uncinnatus, ist, wie sind diese Zysten zum Hauptpankreasgang. Die größte Autorin, der Bachte in Marseille, würde sagen, dass man könnte theoretisch auch Zysten, die 2 Millimeter weit von dem Pankreasgang auch mit RFA abladieren. Ich würde das mit großen Respekt dann nehmen, wegen den Duktusschaden.
Wäre ein Stenting des Hauptganges dann die Lösung, dass man den schützt damit?
Ja, es gibt Serien, wo man das gemacht habe, wobei man, also theoretisch, es stöhnt wie eine gute Idee, wobei man muss auch davon ausgehen, dass die Komplikationenrate für Pankreatitis bei Ablation sind 3 bis 10% ungefähr. Eine Einlage von einem Pankreasstent mit einem RCB hat ungefähr genau die gleiche Rate für Pankreatitis-Risiko. Also es war versucht in manchen Serien. Statistisch macht es meiner Meinung nach nicht unbedingt Sinn, weil man nimmt mit die RCB ungefähr gleich Risiko für die Pankreatitis.
Wir waren vor Ort beim Barte mit Rainer, Beat, und er hat uns gesagt, dass er es am Anfang gemacht hat, also prophylaktisches Stenting sogar, aber danach in den weiteren Serien, als seine Expertise auch zugenommen hat, hat er das nicht mehr gemacht. Und nach wie vor bleibt für ihn ein sicheres Verfahren, wie wir die Komplikationen dann gesehen haben. Und das alles hat auch mit zunehmender Expertise zu tun.
Wie schaut es mit der Nachkontrolle aus bei den zystischen Veränderungen, die ich dann verbrannt habe? Wenn ich nichts tue, habe ich ja ein schönes Bild und kann schauen, ob Knoten wachsen. Wenn ich jetzt eine RFA habe, die inkomplett ist, habe ich da nicht ein Problem, dann wirklich die Nodeli noch zu sehen.
Im Prinzip nach wie vor, also die Bildgebung, also mit einer MR, ist eigentlich der Goldstandard für solche Läsionen. Und man würde dann die Kontrastmittelaufnahme erkennen können, falls da eine Restläsion da wäre, insbesondere bei den Netzen natürlich. Für das Adenokarzinom man würde dann schauen, wie diese hypodense Struktur, ob sie dann weniger ist im Verlauf oder nicht. Aber MR bleibt nach wie vor der Goldstandard für das Follow-up. Gibt es sonst weitere Fragen? Dann vielen Dank alle und ich glaube, wir sind on time für das Lambert Tumor Board. Einen schönen Tag noch.